Hello and welcome to another edition of the NeuroOp Guru. I'm here with my good friend, Dr. Drew Carey. Hi, Drew.
Hey, Andy.
And today we're going to be talking about pre-treatment features associated with vision improvement following radiotherapy for optic nerve sheath meningioma. So, Drew, maybe you could just give us the background of why this is important.
Yeah, that's a good question. So patients will come in with slowly progressive vision loss, and as neuro-ophthalmologists, we'll order an MRI scan. And when we find that it's an optic nerve sheath meningioma, and we're counseling them about treatment options, a lot of meningiomas are removed surgically, but we do not do that for optic nerve sheath meningiomas because of the high risk of further damage to the optic nerve and vision. So the options are typically observation or radiation. And the patients may want to say, well, radiation isn't that for cancer, isn't that dangerous? And they depend on us to counsel them as to the risks and benefits of the radiation treatment. A lot of times it's hard for us, we say, oh, some patients get better, some patients remain stable, some patients might lose vision in 2 to 7 years due to radiation damage. So if we can have some criteria by which to say this percentage of patients are going to improve, this is, do they improve peripheral vision, central vision, and if there's a good way to predict who might be have a good response or a high amount of vision improvement with radiation therapy, that may help patients make that decision.
We don't need a biopsy, we can just have an MRI. Is that right?
These are patients that were diagnosed with presumed optic nerve sheath meningioma. They were not biopsied because biopsy is risky in these patients. There are different things we can do to try and make ourselves feel more confident that this is an optic nerve sheath meningioma. Certainly, if it's been there for a long time and has remained stable, that's helpful. Most of these patients don't have pain, so it's likely not inflammatory. A CT scan can be very helpful if it shows calcification. That really increases the chance that this is an optic nerve sheath meningioma. And sometimes they'll have, a little nubbin involving the anterior clinoid or the sphenoid planum, and you can see that growing and extending into the optic nerve sheath through the canal, and that makes you feel a lot more confident as well. You can have mimickers. Sarcoidosis can look like this. IgG4 disease can look like this. A dural-based lymphoma can look like this, and some of our lymphoproliferative histiocytic processes can look like this. So in atypical cases, you may want to get a biopsy if it's pain, rapid vision loss. There's no calcification, although not all meningiomas are calcified.
So, what did they find in this study, Drew?
Great question. So it was a single center study, retrospective. They identified 26 patients over a 10-year period that were treated. They all had fractionated radiotherapy treatment over 20 to 30 treatments, essentially to keep the dose per fraction low and what we'd like to think is a within the optic nerve tolerable dosage. And they showed that 59% of the 17 patients that actually ended up getting treated had either improvement of visual acuity or visual field. Now the mean visual acuity was poor for a lot of the patients. The mean visual acuity only improved from 2250 to 2200, and you may say that's not a lot of improvement. That's still legally blind if that was their better seeing eye. Turns out if they had better vision, 2060 or better, the vast majority of those patients improved to 2020. And even if they didn't have significant improvement in visual acuity, a lot of them did have pretty significant improvement in visual fields. These patients started with very dense scotomas in their visual field with a mean deviation average of minus 23 decibels, and the mean improvement was to minus 15 decibels. And again, patients with better baseline vision were more likely to have better vision at outcome. So big take-home points, bigger, greater vision outcomes if you have better baseline vision, a smaller tumor, or if there's an inflammatory component to the tumor with recent progression that results in shrinkage on the MRI scan. That doesn't necessarily mean you want to radiate your patient who has a minimal visual field defect, but you definitely don't want to watch them until they're blind and then say, well, let's treat you now because your ship's probably sailed.
That is fascinating. And how are you using this information in the clinic? Are you telling people who have bad vision, look, it's less likely? Are you telling them the baseline vision is predictive, or are you just doing what you used to do, but you have some more data?
Yeah, I think it's helpful for the patients who are really on the fence about treatment. If they say, I'm really scared about it, I notice it in day-to-day life, but I can still, function. we can talk to them and say, listen, if you wait too long, we're not going to get vision back. We can monitor you closely, but if we see it, start to change, I think we need to be more aggressive and really think about treating this. For the patients who have really poor vision and have had poor vision for a long time, I think intuitively we expected that they were not going to get a lot of vision back. But I think it's helpful for counseling them, particularly if they're an older patient. It's going to be a big burden for treatment. Now, sometimes those patients, instead of doing fractionated radiotherapy, they'll go on to have like stereotactic radiosurgery to prevent growth. And that this can help counsel them like, hey, what should I be doing? Should I be doing, 26 treatments or should I be getting 5 treatments? And it depends on what the goal of the treatment is. Is it preventing growth or are we trying to recover vision?
Well, thank you so much again, Dr. Carey, for another edition of the NeuroOp Guru, and we'll see you guys next time.
Always fun. Thanks.